5, 4, 3, 2, 1.
Hello, everyone. My name is Elise Sweeney Anthony, and I'm the Executive Director of the Office of Policy at the Office of the National Coordinator for Health Information Technology. Thank you so much for joining us today. Today kicks off our new webinar series, which is titled, What Clinicians and Other Healthcare Providers Need to Know, an introduction to information sharing under the information blocking regulations. Today, we have a jam-packed agenda of items that we will be going over. But before we get to that, a couple of housekeeping items. So first, let me note that the presentation today, as well as the audio recording, will be available on our website. This will be my first plug for our website, which is healthit.gov. Not only will you find a number of webinars that we've done already on information blocking and a number of other topics, but you will also find fact sheets and frequently asked questions related to the information blocking regulations. So please do take a check and take a look at the website. A couple of other things to note, and for those who are just listening by audio, I'll read the general disclaimers for today. The information in this presentation is based on the regulations in 45 CFR Part 171. While every effort has been made to ensure accuracy, this presentation is not a legal document. Please note that other federal, state, and local laws may apply. Examples are merely illustrative and may be simplified for ease of discussion. Any practice, act, or omission that implicates the information blocking regulations may come under investigation by HHS. This communication is produced and disseminated at U.S. taxpayer expense. So with those read, I want to highlight a couple of things before I turn it over to our national coordinator. As I mentioned, this presentation is pretty full, but you will notice that at the bottom of your box, you'll see a Q&A box. And we will be able to answer some questions throughout the presentation through the chat function. But because this is a pretty full presentation, we may not be able to get to all of your questions. Now, that said, this is just the first in our webinar series, and there will be several others to come, including ones focused specifically on exceptions, et cetera. And we will also have an Ask ONC session, which will provide an opportunity for you to ask ONC questions about the information blocking regulations. And that will be on September 24th. So as you can see, much more to come. But to start us off, let me introduce you to Mickey Tripathi, our national coordinator. Mickey?
Great. Thanks so much, Elise. And welcome, everyone. And thank you so much for joining. This, as Elise said, is the first of a set of webinars on the information sharing for the information blocking regulation. Why do we call it that? The reason that we go through that tortured phrasing is because I believe it's really important for us to think about the information sharing aspects of this. The information blocking regulations are, obviously that it is regulatory. There's a compliance, piece to it, but there's also a strategic opportunity piece that all of us in the industry have been waiting for. All of us in the industry have been waiting for the opportunity to be able to share information, to get the information that you want to provide better care, to get the information to your patients in more seamless and easier ways. And all of us have been waiting for that for a long time, I think. And so I think that we obviously need to be thinking about what does the regulation say? How do all of you meet the requirements for being able to sort of fulfill the requirements of the regulation? But more important, I would argue, is how do you think about the opportunities that's going to give you to be able to get the kind of information sharing that you've been looking for as a clinician, as a provider organization, to be able to provide higher quality, better quality and safer care for all of your patients, which I know is sort of what everyone is focused on here. So I very much welcome all of your feedback and thoughts as you go through this. This is the first of a number of webinar series, and we also have a number of other channels that we're making available to provide information to all of you, and also channels for you to be able to provide questions to us. So we very much welcome all of your questions and thoughts as we move through this process. We're very focused on providing all of you the information that you need to be successful in this what is a large transition, and we recognize that it's a large transition in thinking about, and it's supposed to be, in thinking about how we want to move from a sort of environment where information is shared only under sort of the rubric of it being permitted to be able to share, to one that says that we all have an obligation to share information with other authorized parties to make sure that that information is being used for the betterment of patients at the end of the day. So that is a big change. We recognize that, and everything that we're trying to do is trying to help everyone with that transition. And we welcome your feedbacks and we welcome your engagement going forward. So thank you again for participating, and let me turn it back to Elise, or I might be turning you over to Tom Mason. I forgot.
Yeah, I'll kick us off and then we'll go to Tom. Next slide, please. So I just want to go ahead and introduce your kind of panel of speakers. You all know me already, Elise Anthony, but as Mickey mentioned, Tom Mason, who is our clinical medical officer, will be presenting as well, with Rachel Nelson, who is our Director of Compliance and Administration in the Office of Policy. So before we go a little further into the kind of the deep weeds of what we're going to be talking about today, let me turn it over to Dr. Mason.
Thanks so much, Elise, and thanks, Mickey, as well. I just wanted to, again, thank everyone that's joined the webinar. We did an extensive amount of outreach to the clinician community to ensure that we were reaching out as far and wide as possible to inform you of this rule and the benefits, things that you need to know. I know that there are a number of you that may be hearing about this for the first time, so we wanted to give really briefly some background and overview of the rule. So the first point I wanted to mention is that in 2016, with overwhelming bipartisan support, Congress passed the 21st Century Cures Act. The law not only provides funding and resources to advance biomedical research, as well as efforts to develop new cures for disease, it also has an entire section focused on the advancement of health IT. One key provision of the law addressed feedback that Congress was hearing from the clinical community, from patients and others, that electronic health information was not flowing appropriately in the market. And the information sharing provisions of the Cures Act were enacted in response to these concerns that certain stakeholders and companies were engaging in practices that were limiting the access, exchange, and use of electronic health information. So Section 4004 of the Cures Act focuses on information sharing and defines provisions for addressing information blocking. Last year, ONC published our Cures Act final rule, which implements the interoperability requirements outlined in the Cures Act. We're focused today on the information blocking regulations, which are only one aspect of our final rule. This slide outlines some of the benefits of the rule from the perspective of a patient, from the perspective of clinicians and other healthcare providers, health IT developers and innovators, and how we can all improve the way that care is delivered by sharing information through the use of technology. And at this point, I think I'll pass it back to Elise to talk about the learning objectives for today.
Thank you so much, Dr. Mason. So as we start out, I see a couple questions coming in. Again, this session is being recorded and will be available on healthit.gov shortly. To start out, so our learning objectives for today, and again, keep in mind that this is the first in a webinar series. So we thought it would be helpful to start with some of the foundational elements related to the Cures Act final rule, provisions around information sharing and information blocking, specifically focused on the information blocking regulations. So we're going to talk today about the definition of electronic health information. We're going to talk about what does interference mean. We'll also talk about the 8 exceptions that are available for purposes of compliance with the information blocking regulations. We'll also talk about enforcement roles, how to report and share with us if you think that you are seeing occurrences of information blocking. And we'll also talk about resources that are available and where you can find more information. Next slide. So to start out, just to provide an overview of the section 4004 of the 21st Century Cures Act, which lays out the information blocking requirements that Congress has asked HHS to set in place. In 4004, there's a definition of information blocking. It also notes that the secretary should identify reasonable and necessary activities that do not constitute information blocking. In other words, some type of blocking of information has occurred or information has not been shared, but there's a reasonable and necessary explanation or reason why that has happened. Now, we refer to those in the regulations as exceptions, and we will talk about what those 8 exceptions are. It also tasks ONC with identifying and putting into place a standardized process for information blocking claims to be received. And we've set that up, and that is already stood up on our website. We also, also under Section 4004, it tasks the Office of Inspector General with investigating claims of information blocking. And of course, 4004 also prescribes the sanctions for information blocking that may attach. And those depend upon what type of actor you are. And we'll get into that, whether you are a developer of certified health IT, a health information network, a health information exchange, or as many of you who are joining us here today are healthcare providers. Next slide. So what is information blocking? And on this slide, you have the definition of information blocking that's in the regulation. And you can see there's multiple parts to that definition. Sometimes we refer to them, or we talk about the elements of information blocking, but we thought it would also be helpful to lay out the definition. And I'm going to highlight just a couple of those here today. So first, I wanted to note that except as required by law. So in some circumstances, there may be situations where information should not be shared as required by law. There also could be situations where an exception applies, one of those 8 exceptions that we'll talk about a little bit later. And in those cases, whether information blocking has occurred, we'll look at those 2 components. You would also look at things like, has an interference actually occurred? And interference with the access, exchange, or use of electronic health information. And if you look on the bottom right of the slide, you see that interfere with or interference means to prevent, materially discourage, or otherwise inhibit the use of electronic health information. And that becomes pretty important when you're thinking about whether you are in compliance with the information blocking regulations. A couple of other things to note are located in A2 and A3. And in A2, it says that a health information technology developer of certified health IT, health information network, or an exchange can be an information blocker if they knew or should have known that what they were doing would interfere with the access, exchange, or use of electronic health information. Now, the reason I point that out is you can see that that is a different standard than what exists for the healthcare provider, which is located right below. For healthcare providers, it is a different standard, and it's whether the provider knows that the practice is unreasonable and is likely to interfere with the access, exchange, or use of EHI. Now, again, this becomes important in looking at the facts and the circumstances of any particular scenario or situation, and whether, as a healthcare provider, you knew that what you were doing would be considered or would fall under this definition, whether that practice is unreasonable and is likely to interfere with access, exchange, or use of that EHI. A couple of other things to note, which we'll talk about in following slides, are around the definition of EHI. What does that include? And when does it include it? And that becomes important as well. So let's go to the next slide. And on this slide, you see the definition of electronic health information. Now, some of you may be familiar with some of the terms that are noted here, particularly if you are familiar with HIPAA, where you can see that the definition of electronic health information hinges particularly on the definition of electronic protected health information, and that definition as it exists under HIPAA. It also points to the designated record set. So specifically, EHI is electronic protected health information that would be included in a designated record set, regardless of whether it is maintained by or for an actor required to comply, that is required to comply with HIPAA. So whether or not you are under the HIPAA rubric, the definition still applies to you as it relates to EPHI and the designated record set. A couple of other things to know. So from current now, or April 5th is when it started, but now until October 6th, the definition is a bit smaller. And that definition is focused on the US Core Data for Interoperability, or the United States Core Data for Interoperability, which is the US CDI. And basically, what we say is that any data that is represented by the data elements that are described in the USCDI are in scope for purposes of EHI. So that means that from now until on April 5th, really from April 5th, April 5th, 2021 through October 5th, 2022, which means that starting on October 6th, there'll be a different definition, right? So from April 5th to October 5th, The definition of EHI is focused on the data elements that are represented in the US CDI. Now, that does not mean that it has to be according to a particular interoperability standard. It is about the data itself, the data elements, and not the standard that attaches. So now I talked about all of this information from October up to October 5th. So what happens after October 5th? So on October 6th, as you can see on the bottom of the slide, the definition of EHI is no longer limited to that data that is related to the US CDI, okay? So that becomes really important. And the broader definition, which is noted in bullet 1, becomes critical. Now, additional things that we also get some questions about often is around EHI, what it excludes. So it excludes psychotherapy notes, and it also excludes information compiled in reasonable anticipation of legal proceedings. And that's currently as well as after October 5th. So we'll go to the next slide. And here, I just wanted to highlight, this is what the US CDI looks like. So this is the type of information that would be required through October 5th. And this becomes really important for folks to look at. We do have on our website this slide, but we'll also include it in the deck, of course. Now, a couple of things to note here is any notes, and we get some questions around clinical notes, and you can see that kind of in what would be column 2, I guess, clinical notes at the top. Any notes that fit in the description of any of the 8 types of clinical notes would be included in the US CDI for purposes of information blocking. And clinical notes and other data that meet that EHI definition, when they are or would normally be used to make healthcare decisions about an individual, is part of that universe of EHI. So it's really important to look at if and when you would use something to make decisions about the patient's care, because that is part of the analysis for whether it is considered electronic health information. So with that initial kind of look at some of the foundational elements, definition, and constructs associated with information sharing under the information blocking regulations, I want to turn it over to my my co-presenters as well, Dr. Mason and Rachel Nelson. So let's go to the next slide, please. All right, and now we're going to get into some of the particular questions that we've heard from providers and highlight those for you to take a look at. Again, please do check out our resources that we have available. We'll try to answer some questions in the chat, and keep in mind that we do have an Ask ONC kind of office hours session coming up. So we hope that you join that as well. And that will be on September 24th. So with that, Dr. Mason, Rachel.
Good afternoon. And picking right up here, a question we get a lot is, what individuals and entities are subject to the information blocking regulations? Or more colloquially, folks say, what do you mean by actors? Information blocking, you talk a lot about actors. Actors is a term that we use in the regulation, and we use when talking about the regulations as a short way to refer to all types of stakeholders that the regulations cover, instead of having to always say every time what you see on the screen. They apply to health IT developers of certified health IT, health information networks and health information exchanges, and healthcare providers. Next slide, please. One thing while we're transitioning slides, I want to note, health IT developers of certified health IT includes both developers who participate directly in the ONC Health IT certification program and others from whom you might have seen certified health IT, like resellers or aggregators, people who offer certified health IT products. Certified health IT products, as you all know, are required to meet the criteria listed on their certificates, and their developers who participate in the program are required to meet conditions and maintenance of certification requirements. We've covered that a little bit more in prior webinars, and we will continue to provide opportunities for you all to hear more about that. So we're really not going to dig into what developers would be exactly what they're expected to do, besides to say that in order to maintain good standing under the program, they are required to not engage in information blocking. And now back to the next question. Which healthcare providers are covered by the information blocking regulations?
And I can jump in here, Rachel. I just wanted to add that we've done a significant amount of outreach to stakeholders in the clinical community related to our rule. We've received a number of letters and questions related to the rule. Rachel just covered one as far as the question that we've been hearing about the term actors. But we wanted to make this presentation a bit more interactive. So the format we'll use is I'll present to Rachel questions that we've been frequently hearing from the clinical community, and Rachel will reply with an answer for our most frequently asked questions. And this first question here is, I'm a pharmacist. Am I considered a healthcare provider subject to the information blocking regulations?
Yes, as we put a lot here on this slide, but yes, pharmacists are on the list. As you can see, the definition of healthcare providers in the information blocking regulations is very inclusive, and pharmacists are specifically on it.
Great. And another question we hear often is a clinician, hospital, or other type of provider who does not participate in Medicare or Medicaid still an actor under the information blocking regulations?
Yes, the definition of healthcare provider for information blocking is very inclusive, and it does not turn on whether the provider participates in any particular federal or other program.
Got it. Thanks, Rachel. That's helpful. Another question we've heard is, are clinicians and healthcare providers who do not use any certified health IT subject to the information blocking regulations?
Yes. Not only does it not turn, the definition of provider does not turn on whether you use any particular type of health IT, and it does not require you to have or use specific types of health IT in specific ways by specific dates. Instead, the information blocking regulations include the definition we talked about a little earlier, and we include, we'll talk in a couple of minutes about exceptions. There is an exception called the content and manner exception that provides a framework for responding to requests for EHI in as interoperable a way as you can support. Next slide, I think. I forgot to mention, it's on the bottom of the slide. If you want to access the healthcare provider definition in a really user-friendly way, even apart from this presentation, we have a fact sheet and it's up now on healthit.gov. Now, before we get into the exceptions, I want to pause a little bit and point out this feature of the information blocking definition where it says except for, it excludes practices required by law. And just to give a little bit more about that, because we do get questions, what does required by law mean? What kind of laws are you talking about? And we're talking about statutes, regulations, court orders, binding administrative decisions, federal, state, or tribal, whichever are applicable to you and the information in question in your particular circumstances. So it's fairly broad, but it does need to be required by law to be outside the definition of information blocking. Something that a law merely says you can do it if you want to, that doesn't require you to do it. So with that said, because that addresses a question that I've heard fairly often from stakeholders, which is what exception covers this specific thing that I'm required to do by my state's law. And you might not need an exception, because if it's specifically required to comply with the state law, it's outside the definition of information blocking. Next slide, please. And now exceptions. So the norm is to avoid actions or omissions. We call those practices, just to underscore again that in context of information blocking, we'll often talk about practices having this very specific meaning of actions or omissions that can be committed, and we're not usually talking about, say, an office practice. But the norm is to avoid practices that are likely to interfere with information sharing. But the regulations have established 8 exceptions. These exceptions offer assurance that reasonable and necessary practices they cover will not be considered information blocking. We're not going to dig into the details of each exception today. We're just going to look at what they are and some key features of the exceptions as a whole. And the first of those is that they are voluntary. They are intended to cover practices that are reasonable and necessary for particular purposes. There might not be an exception that fits every single circumstance that could arise in our very large and complex healthcare system, but any given practice that may come under investigation by HHS would be reviewed on in a case-by-case basis, considering how all the facts and circumstances of the situation compare to all of the elements of information blocking. And failure to meet an exception does not automatically mean that you are violating the information blocking regulations. It just means that further thought, you do not have that level of assurance that what you did is covered and is outside the definition. So as you can see, some of these are applicable to things you might do that might delay, restrict, or deny access, exchange, or use of EHI in particular circumstances, such as to prevent serious harm to patients or other persons, to protect patient privacy or honor patients' expressed preferences to share or not share their information more precisely. Security exception, things that you have to do to keep the PHI in your care safe, secure, respond to specific threats. Infeasibility exception, which covers an array of circumstances where it's just infeasible for you to fulfill a particular access, exchange, or use. One condition talks about natural disasters and other factors beyond your control. One condition speaks to data segmentation, and we can touch more on that later. One is specific to perhaps things you might need to do to make sure that your health IT continues to perform correctly and support what it needs to support for you to deliver care. And then the other bucket of exceptions is it basically involves procedures for fulfilling. So content and manner. Maybe someone asks you for EHI and you could disclose that EHI to them legally, but you can't do it in exactly the manner they asked for. Maybe it takes a particular technology you don't have yet. The content and manner exception lays out what's the minimum content that you would be expected to share and gives you a framework to look at alternative manners of moving that data, prioritizing interoperability. What manner can you do it that keeps as much of the interoperability as the information has in your system as you can. And then fees and licensing have to do with, covering in many situations the cost of setting things up and making sure that health IT and the intellectual property involved is, appropriately licensed for use. That is not the formally stated purpose, but, similar to earlier comments, I'm trying to be a little more conversational today. And that's the layout of the exceptions. Also, we have heard the community calls for a little more talk about what is interference, what we would consider to be interference, and perhaps to talk about some of these things in context of things that might come up in the real world, things that might be seen in the real world. So now we're going to look at some illustrative samples of things. And just as a prelude, little stage setting, at this point, you would not have needed the introduction to know that I'm a JD. So examples we discussed today are illustrative examples, and they're not a comprehensive catalog. Many other types of actions or omissions practices could also implicate the information blocking provision. A determination as to whether a practice would be information blocking requires a fact-based case-by-case assessment that considers all relevant individual facts and circumstances against all elements of information blocking. And please remember, as we go through these samples, for ease of discussion, we're going to focus mainly on likelihood of practices being interference. But again, practices likely to interfere would be information blocking only if they meet all the elements of information blocking. They're not required by law. They're not covered by an exception. They're likely to interfere. They affect EHI. They're done by an actor, so they're done by somebody covered by the regulations. And the actor engaged in the practice had the requisite knowledge for what they did to be information blocking. Next slide, please.
And I'll jump in here, Rachel. I just wanted to reiterate that with our stakeholder outreach and preparation for this webinar, we heard that it would be very helpful to have these real world examples, have the mechanism that we communicate about the rule really be focused on examples that we're hearing questions about. So I'll again pose questions to Rachel that we've been hearing. And the first is, if I've implemented a patient portal that includes the capability for patients to directly transmit or request direct transmission of their electronic health information to a third party, but I choose not to enable that capability of functionality, is this likely to be or unlikely to be an interference, Rachel?
That is likely to be an interference. You have the portal, and we talked about this in the rule. You have a portal. It allows the capability for patients to do that. All you have to do is switch it on, and you choose not to switch on that capability. You're interfering with the patient's exchange and use and access of their EHI compared to what your tech could support right now if you turned it on.
Understood, thanks. The next question, if I have the capability to provide same-day access to electronic health information in the manner requested by a patient or a patient's healthcare provider, but choose to take several days to respond?
Yes, and that is also likely to be an interference. We talk more about that, and I do recommend that folks read these particular chunks of the rule where we talk about things that are likely, practices that may implicate information blocking, and examples of practices likely to interfere. It can provide much more sort of context and much more of our thinking than what we have time to go into today. But you might notice a theme here. You have the capability to do it. You could do it, and you simply choose not to. That is likely to be an interference. Now, I do want to say there could be reasons to choose that might be consistent with an exception. So remember, we're trying to give relatively simple answers and give some specific examples to try and illustrate, as Dr. Mason said a moment ago. What are some things that might fit this description of interfere with or interference, meaning to prevent, materially discourage, or otherwise inhibit?
Got it. And this next question comes from the clinical informatics community. If I've implemented a FHIR, which stands for Fast Healthcare Interoperability Resource, API, Application Programming Interface, that supports patients' access to their electronic health information via an app, but refuse to allow publication of the FHIR endpoint, is that likely to be an interference?
Yes. Without that endpoint, again, we say more about this in the rule itself, but without that endpoint, it's going to be real hard for patients to actually get an app and for that app to actually connect to that API. So you have to be able to find that patient access API's front door, if you will, in order to be able to use it to obtain access. So yes, this would be a practice that would interfere.
Okay, next slide. The next question. If I establish an organizational policy to delay the release of all lab results until the ordering clinician reviews the results for potential risk of harm associated with release, is that likely to be an interference?
That is likely to be an interference. It interferes with a lot of patients' access, exchange, or use of their EHI. And I will say, if you look at, we've provided in a number of these places specific points where you can start to learn more about the example, about the things raised in the example. And one of the places we've noted to start here are our FAQs, frequently asked questions. And we have several frequently asked questions that are relevant to this, including the likelihood of interference. And there's one of these FAQs touches on the fact that this organizational policy of this uniform indiscriminate delay would not be consistent with the requirements for the preventing harm exception to cover it.
That's what I was going to ask, Rachel, if you could talk a little bit about the tie-in here with the preventing harm exception.
So the harm exception, I'm sorry, my voice is a little bit what it is. So for the harm exception, the answer is, would the harm exception, if the question were, would the harm exception cover this? The answer per our FAQ would be no. Blanket delays that affect a broad array of routine results do not qualify for the exception. It is designed to cover only those practices that are no broader than necessary to reduce a risk of harm to particular patients or other persons. And rather than dive into the rest of that FAQ here, because it's 1:41 p.m., I am going to suggest everyone, and I think many of you are interested in this, please start with the FAQs and plan to come back to our future webinar events.
Thanks, Rachel. So next question, if I direct my EHR developer to configure the technology so that users cannot easily send referrals / electronic health information to unaffiliated, providers whose direct addresses the user has.
Yes, that is likely to be an interference.
Okay. If I educate patients about the privacy and security risks posed by a third-party app with information that is factually accurate, unbiased, objective, fair, and not deceptive in a non-discriminatory manner.
And I apologize that that question was is phrased. We phrased that question as precisely as we did, but yes, the answer is that is unlikely to be an interference. And if you want to see that more about that in writing, please look up IB FAQ number 27. And we said, as long as it's factually accurate, unbiased, objective, fair, and not deceptive. So you're not doing this in a discriminatory manner. Then just making sure patients understand that there are privacy and security risks is not in itself an interference. Yes,
I was going to mention that it's clear that this question got to our lawyers in a little bit of editing. So I appreciate you reflecting that, Rachel. Next question. If I choose to provide access, exchange, or use of only those clinical notes authored by a physician, regardless of what patient or another provider seeks?
So this is likely to be an interference. If someone asks for particular information, they're seeking information, the scope of what you give them can be tailored to what they want, as long as you didn't, steer them or give, artificially kind of restrict what they asked for. So the key here is you're choosing. You could, and they want, or they haven't told you not to, access to all of the clinical notes that you have for a particular patient, and you just choose to only give them the physician notes, even though perhaps they really want the nursing notes. Depending on the type of circumstance, those could be very relevant to their care of the patient. That would be an interference, because you are there, and you are, even during the USCDI period, interfering with access, exchange, or use of information within scope for information blocking.
For this, go ahead. No, go ahead.
Yeah, just a brief word, a brief interlude about the, we do get questions about information blocking regulations and HIPAA business associate agreements. Today, I think we're going to be, we're talking primarily to providers. You may have business associates in the audience with you, but as we cover on the slide, we recognize that, under the HIPAA privacy rule, the business associate agreement must contain certain things, and you kind of govern what the business associate can do with and to the information. The information blocking regulation does not require an actor, which would include your business associate, to violate the business associate agreement. However, the agreements must not be used by either of you in a discriminatory manner to forbid or limit disclosures that would otherwise be permitted by the privacy rule. And Dr. Mason?
Yes, so if I enter into a business associate agreement that prohibits or limits the access, exchange, or use of electronic health information by other healthcare providers treating the patient,
that is likely to be an interference. Disclosures to those other providers for purposes of treatment are permissible disclosure under HIPAA. So limiting that sort of access, exchange, or use could be an interference.
Got it. If I use a BAA in a discriminatory manner to forbid or limit disclosures that otherwise would be permitted by the privacy rule.
Likely to be an interference. You're shaping where information goes, and you're interfering with legally permissible access, exchange, or use for some reason that has not, it's not required by law. You're doing this for some reason of your own. Next slide.
If I tailor the amount of electronic health information that I share to what is sought without artificially restricting or otherwise influencing the scope of EHI sought.
So that is probably not an interference, but whether or not it's interference is maybe not as directly kind of relevant a question. That's why you don't see the checkboxes on this slide. What we've said, and you can look at the FAQ, you can tailor what's shared to what someone is looking for, and obviously what you share needs to be limited to what you're legally permitted to disclose in a particular circumstance. But even within what you're legally permitted to disclose, you can tailor it as long as you haven't artificially restricted or influenced what they're looking for. The other thing we touch on in this FAQ, and I saw earlier on, I saw some questions in the chat that suggest it might be useful to surface. The same frequently asked question also touches on, what do I do if some of the information that I have, some of the protected health information in the designated record set that I have about a patient is actually on paper, so it's not electronic. And the FAQ covers that the actor is only required to fulfill a request with the requested electronic health information that they have and that can be permissibly disclosed. However, just remember, if you have it and you don't maintain it electronically, so it is not EHI, not under information blocking, all HIPAA requirements would still be applicable, which would include the right of access should the patient or their personal representative choose to exercise their right of access.
Got it. If I charge an individual, their personal representative, or a person or entity designated by the individual for electronic access to the individual's EHI. And
the thing that is important to remember here is that we did say in the rule that charging fees for access, exchange, or use can interfere. They can inhibit. We do have a fees exception, as noted earlier, that can cover costs. And the thing about this particular use case is if you're charging an individual or their personal representative for electronic access to information you already have electronically, and you don't have to do any special manual effort to get it from another system into that system. You don't have to scan it in to make it into EHI from the paper that it's sitting on. Any fee for that is going to be suspect. But if you go through the fees exception, you'll notice you're not permitted to charge a fee that is impermissible under the individual right of access if you want coverage by the fees exception. Any fee for electronic access that requires no behind the scenes manual effort to get it from one system to another, for example, is suspect and possibly not covered by that exception. So I think what I really want to highlight here is if you're thinking about charging someone essentially exercising the right of access one way or another, you really want to look at the fees exception and see what the conditions are for that fee to be accepted from the information blocking definition.
Got it. I know we're running short on time. This next question is one that we've heard a lot of input on and wanting to better understand. If I lack the technical capability to segment data, the patient has refused to consent to disclose from other EHI, that I could permissibly disclose to another provider for treatment purposes.
And that's some special purpose or special restriction information, as some stakeholders have referenced it to us, because as we are used to working with, most of the time, disclosure of protected health information for treatment payment operations purposes under HIPAA is permissible. But basically, what we have when we have a situation where patient has had the opportunity to consent and they've withheld it, consent is a precondition for to be okay to share this specific information. I think as we said in the rule, the first thing to think about is, well, is it that I can't segment it at all, or that I can't segment it in the exact manner that the other provider first asked for it? Now, maybe you can't. And if you just cannot segment that data in any way that you could move the data to them, then you would want to look at the infeasibility exception and whether what you're doing is consistent with the infeasibility exception.
Thanks, Rachel. And I'm also monitoring the chat. Just wanted to mention that I'm Dr. Thomas Mason, Chief Medical Officer at ONC, and this question and answer dialogue is with Rachel Nelson, the branch chief of our Regulatory and Policy Affairs Enforcement branch at ONC. But back to you, Rachel. I just wanted to mention that for those, since we're not on a video due to the webinar.
Yeah, and we are coming down the home stretch here. Some things to consider. Folks have asked for, what should we be thinking about? And as we're trying to gear up our compliance and, review your policies and processes. Are you optimized? Is it optimized for you and your staff and your patients to access, exchange, and use EHI whenever it is legally permissible and consistent with the patient's expressed preferences? Example, have you gone back and removed any of the requirements that you put into your policies? You're not legally required to have them, but you put them in there. Requirements for ink signatures on paper or in-person verifications. That, again, the law doesn't require, it's just something that got put in maybe back in the day when we were all used to everything happened on site or it didn't happen. So just kind of look at your policies, and there could be many more examples of places where your policies are not optimized to share information when you can in the technology environment we're working in today. Review your technology. Are you making the most of its capabilities for facilitating information sharing? Are you still printing and faxing public health reporting information that your public health department would rather receive in the secure interoperable format that if you have a certified EHR, your certified EHR supports? Are you talking to your developer about enhancing the capabilities to better meet what you and your patients would want in terms of capabilities to share information and to make it easy for you all to share information with each other and with others that you need to share it with? And with that, I'm going to turn the the final portion of things to consider back over to Dr. Mason.
Thanks, Rachel. And I wanted to talk a bit about feedback that we've heard from the clinical community related to aspects of the rule related to the timing of release of lab and test results. And we've heard a significant amount of feedback from both hospitals, ambulatory practices, private practices, and we've had a spectrum of feedback. And where we've heard successes in implementing this aspect of the rule were when workflows have been implemented to engage the patients, either at the point of ordering a lab or a test or during the laboratory process, to inform them that they have the opportunity, they may receive the result before the care team has a chance to review the result, and ask them if they prefer to wait to review the results until the care team reaches out to them with the results, or if they would like to review the results at the time that they are delivered. So that's one strategy that we've heard from an organizational workflow perspective that has had successes in terms of leveraging that process. And also at this point, I know we're running low on time, that there are additional topics that we plan to cover in the next clinician and other healthcare provider organizations that will cover additional topics that we've been hearing. I know we're running short on time. If we could go to the next slide.
Yeah, and we're going to, for those of you who can stick around or want to listen to the end of the recording later, we are going to go ahead and go over our advertised time by a couple of minutes. So for those of you who can stick around or want to listen to us later, thank you. We were trying to get as much information as we could out to you, even in the starter presentation. We get a lot of questions about penalties and enforcement. What are the penalties? When are you going to start enforcing? When that could be against me, it could be against this other entity. Maybe it's a developer, maybe it's a health information network that, you know, as a provider, maybe you feel they're information blocking you. And here's what we can say about penalties and enforcement today. The statute prescribes penalties, or sanctions is another word. For healthcare providers, the statute indicates appropriate disincentives to be established in regulations. Those regulations are still to come from HHS, but, you know, stay tuned. They will be notice and comment regulations, so there'll be a proposal. Stakeholder community will have opportunity to comment on it. We do not have a time frame that we can share publicly for when to expect those regulations. For other information blocking actors, the networks and exchanges, the health IT developers of certified health IT, the statute itself, the Cures Act, authorized civil monetary penalties up to $1 million per violation under OIG's enforcement authority. Under ONC's separate parallel authority, a developer who participates in the program, if they violate the conditions of certification, which include don't information block, they can get a certification ban. And we publicly list certification bans as well as terminations of certification of products. Timing for enforcement of information blocking civil monetary penalties, which again apply to the Health Information Network, Health Information Exchange, and Health IT developers of certified health IT actors, will not begin until some procedural hurdles are cleared. by an OIG final rule. That final rule is expected later this year. The last I looked at the unified agenda, government-wide unified agenda for regulatory activity, the published expectation date said September of 2021. So stay tuned for the final rule, which will include what the effective date is of the OIG rule, and therefore the earliest date that enforcement could begin against information networks, health information exchanges, and the developers. Next slide. I want to put in a plug so you guys know there were a lot of questions, and there's no way we're going to be able to answer all of them today or even potentially address them today, even with additional colleagues behind the scenes working on the Q&A and the chat. So I want to make sure you know in between events that, you can ask us a question or you can report a concern where you think you might be getting information blocked, where someone should be sharing information with you and they're not. I want to make sure you know where you can go to ask a question or report a concern, and that would be healthit.gov/feedback. Separate buttons to say you think you saw information blocking versus ask a question about information blocking. On the report information blocking, a couple things that frequently come up from the stakeholder community is, if I report my developer, will they immediately know that I'm the one that reported them? And the statute does provide some protection from public disclosure, such as through Freedom of Information Act requests of information that would identify who submitted particular complaints that someone else may be information blocking. There's also an option to submit an anonymous complaint about potential information blocking, but please note that if you do choose to submit an anonymous complaint, please be as complete as you can in giving us all the information you can about what you've seen and why you think it's a problem, because we won't be able to communicate back with you. If you click, I want to stay anonymous, you will be anonymous to us, and there will be no way for us or OIG to contact you about that specific, your specific submission, particular report. So you don't have to report anonymously, you do have that option. And if you choose not to be anonymous, there are protections against general public disclosure of who complained. Questions, obviously, you can submit an anonymous question, but again, we won't be able to send you any response. If you have a question and you would like as much response as we are able to give you, please go ahead and give us your name so we can get back to you. Next slide, please. This is just contact information. Make sure you have it. Next slide. Ooh, I think we're going the wrong way. Reminder to stay connected for information on upcoming webinars and events. Subscribe to ONC email updates, and you'll see a little screen snip there at the bottom of what that looks like when you go to healthit.gov, and you can subscribe for our email updates. And if you would like to come and ask questions about information sharing in a sort of an office hours type of an event or setting, please mark your calendars for September 24th and be on the lookout. In the meanwhile, next slide. In closing, we just wanted to leave you with a reminder of where to find more information. Go to healthit.gov/cures rule, and you can find fact sheets, FAQs, blogs, and past webinars. And on the right-hand side, you can see, we kind of pasted in an abridged listing of the past webinars about the Cures rule as a whole, focused specifically on webinars about information blocking. So in the meanwhile, in between our upcoming webinar events and other events, here's where to find more information. And if you want to send us a question, healthit.gov/feedback. And that actually, again, thanks everyone who was able to hang with us as we went a few minutes over time. This concludes our agenda for today. And we will be I do want to say we will be saving all of the questions that you submitted to us during this presentation. And even if we can't get back to you individually, everything you put in there informs our thinking about what to cover in future materials or future events. Did anyone else want to have any closing comments on the panel?
I just wanted to say thanks again to everyone that's joined. We've, are really appreciative that you attended the webinar, and as Rachel mentioned, we're looking forward to the next one so that we can continue to get the word out about information sharing. Thank you.